Hi, Doc. This is our report uh, about preoperative preparation. So, preoperative preparation is the preparation of a patient requiring surgery to optimize post-operative outcomes. The preparation begins from the time of contact of the patient with the surgeon and ends on the day of surgery in the preoperative room. The approach is multidisciplinary. It involves participation of anesthetic and surgical teams, radiologists, pathologists, specialist nursing staff, and operating room staffs. So the objectives: surgical, medical, and anesthetic aspects of assessment, how to optimize the patient's condition, how to take consent, and how to organize an operating list. A preoperative assessment clinic is essential to gather all information, optimize comorbidities, and then organize anesthetic, surgical, and post-operative care before surgery actually takes place. Patients with severe comorbidities should be referred to the relevant specialist to quantify the risk and to take appropriate measures to minimize operative morbidity. Surgery cannot be made risk-free, but risk must be known so that the patient can make an informed decision. Patients should be given advice on when they should be kneel by mouth and what to do about regular medications and pre-medications. A plan for operating list should be drawn up and all those involved in making the list run smoothly should be informed.
So, pre preoperative plan. Plan for the best patient outcomes. Gather and record all relevant information. Optimize patient condition. Choose surgery that offers minimal risk and maximum benefit. Anticipate and plan for adverse events. Inform everyone concerned. So, patient assessment. History taking. A standard history should be taken. A set of fixed questions are needed to determine fitness for surgery. Surgery specific symptoms, including features not present, onset, duration, and exacerbating and relieving factors, should also be documented. So, in cardiovascular history, high blood pressure, chest pains, palpitations, syncope, dyspnea, and poor exercise tolerance. Respiratory system history. History of smoking, productive cough, wheeze, dyspnea, hoarseness of voice, or stridor present. Increasing severity of symptoms generally indicates worsening of the condition. In past history, past surgery and anesthesia can reveal problems that may present during current hospitalization. Intra-abdominal adhesions and succementhonium apnea. Drug history, the use of recreational drugs and alcohol consumptions should be noted as they are known to be associated with adverse outcomes. So, principles of history taking. Listen. What is the problem? Clarify. What does the patient expect? Narrow differential diagnosis, fitness, comorbidities. So, in examination, medical examination in general, anemia, jaundice, cyanosis, nutritional status, sources of infection like teeth, feet, leg, and ulcers. In cardiovascular, pulse, blood pressure, heart sounds, bruits, peripheral edema, respiratory rate and effort, chest expansions and percussion note, breathe, sounds, oxygen saturation. So in gastrointestinal, abdominal masses, ascites, bowel sounds, hernia, genital, and genitalia. So in neurological, consciousness level, cognitive function, sensation, muscle power, tone, and reflexes. In in general, positive findings, even if not related to the proposed procedure, should be explored. In surgery-related type and site of surgery, complications which have occurred due to underlying pathology. In systemic comorbidities and their severity. And in specific, for example, suitability for positioning during surgery.
So, managing systemic diseases. Preoperative management of patients with systemic disease. Capacity. Baseline organ function capacity should be assessed. Optimization. Medication. Optimization. Medication, lifestyle changes, specialist referral will improve organ capacity. Alternative. Minimally impacting procedure. Appropriate post-operative care will improve outcomes. Theater preparations, timing, teamwork, special instruments and equipment, risk assessment and consent. So, risk related to the comorbidities, anesthesia and surgery. Explain the advantages, side effects, and prognosis. So, the language to use is simple. Use daily life comparison to explain risks. Consents. Valid consent is necessary except in life-saving circumstances. So, consent. Valid consent implies that is given voluntarily by a competent and informed person who is not under duress. In emergency situations or in an unconscious patient, consent may not be obtained and the procedure carried out in the best interest of the patient. Lastly is the conclusion. The anticipated outcome of preoperative preparation is a patient who is informed about the surgical course and copes with it successfully. The goal is to decrease complications and promote recovery. When patients are adequately prepared psychologically and physically, and policies and guidelines have been followed, the risk of post-operative complications should be low, leading to a quick recovery.